You are listening to the Health and Politics podcast, Prevention is the New Cure.
With former ministers Steve Brine and me, James Bethell.
Hello, James.
How are you, Steve?
I'm good. Normally, I only get to see you virtually, and I haven't seen you since we last recorded, but I actually saw you in person in the real world yesterday. So the real world still exists. Who knew?
Thank you very much. It was an amazing invitation
Yeah.
to see NHS Clinical Fellows. Do you want to just tell
Yeah,
us about
did you enjoy?
what
You
the event
enjoyed
was?
coming? Yeah, well, it's something called the Faculty of Medical Leadership and Management, which clearly, could be shorter. But it's sort of mentioned in the 10-year plan. It's going to become the College of Leadership, the College of Medical Clinical Leadership. And what they do is they've been running for years something called their Clinical Fellows Scheme, which are basically young men and women who recently qualified or are still working through their medical training, and they take a year out and then they attach themselves to a part of the NHS. There may be NHS England, maybe the Chief Medical Officer's office or the Chief Pharmaceutical Officer's office. And there's usually about 35, 40 of them. And for that year, they embed in that team. And they're sort of future leaders, I suppose, of the NHS. And they get to see how the NHS is run from a leadership perspective instead of just a frontline perspective. And that's part of their training. And, some of them have gone on to good leadership positions in the NHS and health and care. And they have this thing called a Westminster Day once a year where they come together and we try and give them a real insight into Westminster. And I sort of helped them out with yesterday. And you and Dame Claire Gerarda. So you've been in the House of Lords quite a number of
Baroness
years.
Gerarda. Yeah.
Yeah, sorry, Baroness Gerarda. Sorry, I've got these things right. She's a new peer, people's peer, and you came and did a double act for us. We also had, before you got there, we had like a journalist panel. So we had Hugh Pym from the BBC and Victoria McDonald from Channel 4 News and Sean Wooler from the Daily Mail, Dennis Campbell from The Guardian and James Halliwell from Chemists and Druggists, which is a specialist pharmacy magazine. We had them come and talk about health journalism, which they really loved. We had Jeremy Hunt as the longest serving Secretary of State. But it was great to see you and to hear about, how health is debated in the Lords. Did you enjoy it?
It was really impressive. They were thoroughly impressive people. It's so important we get this leadership thing right. And there are two things that I took away from being a minister that really struck me. One is culture is defined by clinicians in the health system. And our culture, like in every country, is not great. It is too hierarchical. There's too much poor behaviors at time. If you speak to anyone who runs the sort of health, the human resources side of things, they'll talk about bullying and inappropriate behaviors. That's a shame. Partly because it's not the majority, it's a minority. So having impressive young people like that with a really strong sense of values, feeling that they own the culture is really important. And then secondly, the clinicians, sometimes, listen, the clinical practice is micro by definition. You are taught to be obsessed by the details of someone's condition. And to be able to step back and lead people and to define strategy and to take long-term decisions is a complete jerk from that micro obsession. So to have young people being put in a position where they are taken away from the intensity of their craft and given a macro view of the future of health, I just thought was really useful. And they stepped up to it. And the comments and the questions we got were really refreshing, I thought.
Yeah, they're a very, very bright bunch. After you left, and Jeremy Hunt came and talked about being the longest serving Secretary of State. And then we had this thing called the Select Committee of the Fellows, where basically they had talked to me and the lead of the Health Committee in the Commons at the moment. And then they were sort of they were immersing themselves in it throughout the day. And then at the end, I made them role play, basically being a select committee. I made some of them be members, one of them be the chair, and then some of them be the ministers answering the questions. And afterwards, they said to me, I can see why you preferred asking questions than answering them, because it's not easy, is it? And I was like, no, it's not easy. So it was great. But what was my big takeaway from the day when you came, James?
I can't remember. What was it?
Bethell does porn.
Oh, yeah, I know. Well,
we should explain.
Before anyone gets the wrong idea. Listen, both Claire and I had the same sentiment, which is in our careers, we have done all sorts of sort of big deal strategies and tried to nudge along major endeavors for the reform of the things we're in. But actually, when we measure our value in the world, it is the one or two smaller things that we've had big personal interventions on that we really remember. And very oddly, it is a prevention point, but
Yeah.
I sat next to someone on a tube one morning watching porn on a commuter train and intervened, and we had a big row. And it gave me in that moment an insight into the addictive nature of porn. And I then stepped in and brought in age verification for porn, which was really sort of, something I felt very passionately about. And that has had a big effect on the internet. And it's weird that of all things is probably what I am most proud of during my time in government and parliament.
Yeah, it's funny, isn't it? It's funny, the little things. Miriam Cates, who was an MP
Yeah.
from 29 to 24, now does some presenting on a channel I call GB News. She came storming up to me in the library once and said, "Steve, you were a health minister. We need to talk about porn." And she just said it quite
Yes.
loudly.
Well, she was my partner in crime. Yeah.
Yeah, and she's very good on this stuff. So yeah, we should find a way to talk about this sometime. Anyway, we digress. So special episode today, James. It was World Cancer Day yesterday, and the government published their National Cancer Plan yesterday, Wednesday. And so we are very shortly going to talk to the National Clinical Director, Professor Peter Johnson, all about that plan. So watch this space. That is coming up imminently. And what else?
Well, we've got strikes, I'm afraid. Listen, Steve, it's grim. We've got strikes and waiting lists, and you and I just chatted about whether we could find something more uplifting in this rainy February morning to be talking about. But those are dominant. Shall we start with strikes, Steve? How's it looking on the strike front? I mean, I can barely read the material at the moment.
Yeah, no, I mean, it's really difficult. I mean, obviously, the government came into office and said, if only we were in charge and not the other lot, we would be able to end the strikes. And, as we've said many times, it's proved more difficult than that. Who knew? I mean, basically what's happened is that resident doctors, formerly known as juniors, of course, have voted overwhelmingly in favour of more strike actions. They've already had 14 strikes, and if they have the next will be their 15th strike if they go for the next one. It doesn't mean they're going to, but what they've basically done is their mandate had run out. They've now got another 6-month mandate. They haven't announced any dates yet, but this dispute goes back to spring 23 during the last government's time. So I think 93% of those who voted, there's a 53% turnout. So even with the government's changes to threshold legislation around strike action, it would have passed. But they're about to make it easier for strike action, of course, which I think they may rue that. And so, yeah, I think that what do I think here, James? I think the danger is that we become very yardy-yah about these strikes, and we become a bit blasé, and we say, well, what a lot of people are saying, oh, well, of course, the consultants are in charge and they're decision makers, and the hospitals run better without the juniors being there. So we've sort of become a bit blasé about it. But actually it matters. There are some 75,000 resident doctors working in the NHS. So, they are the backbone workforce. And if you go to emergency department today, you will see junior doctors who will most likely be the first people that you see. So it really does matter. The government have got to solve it. And, the government in Scotland have given a much bigger offer to their resident doctors, and guess what? It's led to calling off the strikes. And do you have any sympathy with this view of the resident doctors BMA here, James?
I would love to pay doctors more. I mean, it is a hell of a skill making life or death decisions several times a day on patchy data. It's really tough. I'm not capable of doing it. So they are miracle workers. I have a sort of detached view on this, which is I just wish they were more productive. The bit that's frustrating is our health system seems to be doing less and less. The underlying health of the country seems to be going backwards, and yet we're pouring more and more money in it. We were just talking about leadership. Well, doctors themselves are part of the answer here. And in this negotiation about pay restoration, I just don't hear any mention of productivity, changes in practices, how to make more out of less. Instead, doctors seem to get more and more specialist. We talked about it yesterday. More and more determined just to stick to a tiny little contribution. And there's no sense of a sort of collective effort to try and address the fundamentals of our national health. That's what drives me nuts. We've got a massive technological revolution, an opportunity to do things in different ways, to liberate the workforce from drudgery. And yet the conversation is entirely sort of a Marxist conversation about the wealth owners and the salary people. It's just so frustrating. And I do challenge Wes and the team. They have not changed the terms of the debate at all. They have not sought to put on the table a really clear agenda for change, to use that slightly awkward phrase. But and I blame my lot as well. We didn't do that well enough. We didn't go out and do what Tony Blair calls winning the argument, that there needed to be professional transformation. And we're still stuck in the gutter on basically how much of the pie the doctors are going to get over everyone else, which is a rotten place to do a negotiation.
It's a bit analog. I tell you what we didn't do either as the last government is, I remember saying this when we were doing the select committee, and we did a sort of mini inquiry on this, is the pay review bodies. I mean, the NHS pay review body is a very, very old-fashioned process, and governments are often behind the curve on it. So the pay review body in recent years has reported after the start of the financial year, so trusts don't know how much they've got to pay their staff, and then it's backdated, and it's all a bit of a mess. And what you want to do is get ahead of that process. It used to be that it would report in the autumn, it would then be measured in a sort of autumn budget statement. By the chance it would be agreed, it would be budgeted for, and then it would come in the spring at the start of the fiscal year. If you have a more considered pay review body process, that can consider all the things that you're talking around productivity and around modernisation. But I mean, in some ways, Wes was the architect of his own problems here, because he gave him this big pay rise at the start without any of that conversation being had. And he's now sort of reverse engineering some of the stuff around the medical training bill, which I know started in the Lords yesterday. And it all feels a bit playing catch up. And meanwhile, the doctors are just saying, to hell with it, we're gonna strike again.
But Steve, I'd go further. You're absolutely right, but I would go further than that. I'm spending the rest of today at a Silicon Valley tech consultancy doing a course on how to use modern technology to professionalize my life. And I'm going to turn my diary keeping and my email and my problem solving and my researching and the way in which I communicate completely on its head. And I'm going to be given new tools. I have to learn loads of new stuff. And I'm terrified, frankly. I rather like the way I do things at the moment. I have to change because I can't keep up with the world stuck in the way I do things at the moment. Where is the similar thing happening? If you were a lawyer or an accountant or a trader in the city, or just about an architect or any other profession, you're on a course like this, and you're going to have to completely reboot the way you go about your role. And if you want to keep up and have your salary, you're going to have to become more productive. I don't see the same thing happening with the clinical professions. And of course, we don't want to have revolutions and turn things on the head and put patient safety at jeopardy. But we do need to transform. And that's what frustrates me about this whole conversation.
The other big story this week, government's rejected an accusation that it massaged waiting lists through making payments to NHS trusts. So there's a Times story on Monday which said that the 86,000 drop in the waiting list, which the government often talk about, has only been achieved by removing patients from the waiting list through a process known as validation. Now we talked about this before, and now Times have come up with this story, which the government have rebutted, but maybe not convincingly. Exactly. I mean, look, there's data clean. So there's two ways of data, or two parts to cleaning the data. One is clinical. So, has the patient died, or has the issue resolved itself, as often they do. And the other part is sort of, have they gone to the independent sector, for instance? So is that, quotes, good housekeeping? Is it efficiency? Or is it sleight of hand? That's sort of where this comes down to for me.
So I have a strong feeling about this, which is what they're doing at the moment is absolutely essential. So deduping, as you say, and cleansing the data has to be done. I had a presentation from Palantir, and they showed me what a lot of the work they were doing, and it really was nothing more than data cleaning. They were sending text and emails and AI phone calls to all of the patients on a list and checking whether they still needed the procedure, had already had the procedure, had passed away, had developed a bigger disease. So getting up-to-date data is critically important. I mean, I don't think it should be denigrated. And to be paid to do that that's how it works. That's the market. That's how, I mean, I've had to look after databases and had to pay people to clean my data. That is not unreasonable. What it does put a spotlight on, though, is the second point, which is there's just been no increase in productivity. The actual number of procedures,
activity,
and the number of people who are getting better. So what's a problem that it's revealed is that for everyone who enters the system with an illness, it's taking more time, more money, more doctors to get them out of the other end. And the pace at which people are coming out the other end has, if anything, slowed down. Now, why is this? People say it's because doctors have become very specialist, that there's been a sort of work to rule kind of attitude amongst some people. Claire Gerarda mentioned that she spoke to a psychiatrist who said he couldn't prescribe basic medicines because it was out of his scope. Whereas he's a consultant with 20 years. I mean, it's sort of bonkers kind of rulemaking that we've got ourselves tangled into. That's the kind of thing that I think is really frustrating top DHSE, NHS management at the moment. It's this kind of weird safety agenda, work to rule, over bureaucratizing of the profession that has slowed everything down.
Yeah, well, when we talked to Jim Mackey on the podcast, which we plan to do, we will obviously ask him about this. But I mean, the department say that, the Times story is not true, that more than 85% of removals from the list are a result of direct care provided to patients. So that seems to be the point of context. I think that just to close on this, I think the point that draws both of this together is sort of the politics part of what this podcast is about. And I think it comes down to authority, James. So, on the BMA strike story, if you're the BMA, why settle when this government feels quite fragile right now and they're wondering who they'll be dealing with as a health secretary / prime minister? And on the waiting lists, whether it's true, partly true, not true, because public faith in politics and in the body politic has taken such a hit as it has this week, given the story around Mandelson, etc., the public faith is low. And so I think both of those stories are drawn together by the fact that there is an authority problem at the heart of government right now. And, we do health and politics, and you can't separate the two. And that's why we do what we do. Anyway, final bit of positive stuff before we chat to Peter. What are you up to this week?
I've just got a ton of very exciting tech connections. So on today I'm doing my AI boot camp, which is going to, I hope, transform my life. On Tuesday, I'm going to be welcoming the Milken Institute to my home for an event on women's health. And there we're going to get health tech leaders who have got amazing and promising ways of plugging these huge gaps we have in women's health. You and I aren't the best people to speak authoritatively about this, but I am totally persuaded. I mean, really genuinely persuaded that this has been a long-standing.
And you were telling me yesterday about the Royal Society of Public Health, which I know you're very involved with. You're doing something quite interesting with them, aren't you?
Oh, thank you, Steve. You're very sweet to ask. I am a trustee of the Royal Society for Public Health. We have been concerned about the falling vaccine thresholds here in the UK. As you know, we're behind on all 12 of our standard vaccines in the UK. And we're also really struck by the opportunities for modern vaccines that are coming on the horizon, in particular, actually, for adults. The children vaccination thing is a big issue, and the measles announcement last fortnight was a real shocker. But actually, an interesting area is how many new vaccines and also recycled old vaccines we should be taking in our 30s, 40s, 50s in order to have a better older life. I took the Shingrix vaccine a couple of months ago ahead of the NHS guidance because I took a personal decision that there was no particular downside, but it could quite possibly head off dementia later on. That kind of thing is coming our way enormously. So we want to address the question of how the NHS, how our health service, how the private sector can step up to this opportunity. I've got a really impressive set of commissioners. We're going to have an evidence-taking process. All of this is set to be announced. So this is a little bit of a curtain raiser on that.
Well, tell us more about that. Anyway, for those listening on audio, let's take a quick break and then we'll chat to Peter. Yeah, so welcome back. World Cancer Day yesterday, Wednesday, and the government released their long-awaited National Cancer Plan. Absolutely delighted that an old friend of mine, somebody that I've worked with for many years, Professor Peter Johnson, who is the NHS National Clinical Director for Cancer, joins us on the podcast. Welcome, Peter.
Thank you very much. No, very good of you to have me.
Well, thanks for coming on. Look, a big day yesterday. I said long awaited because it has been. The last sort of refresh, if you like, of the cancer plan was something I did when I was a minister, and that was, back in the dark ages as part of the NHS long-term plan.
Oh, Steve, you're harsh.
I know. The headline, if you like, that the government put out the night before was 3 in 4 cancer patients will survive long-term under the new cancer plan. So it's a 75% ambition. Patients diagnosed from 2035 will be cancer-free or living well after 5 years. Can you unpack that, Peter, and put it into human speak?
Yeah, so I think I think it's really important when you have a plan like this, and again, you were involved with the previous one, which was actually only just about a decade ago. So if we work in 10-year cycles, not unreasonable to be doing another one now.
Yeah,
thank you.
Although it feels like a very long decade.
Tell me about it.
What you need is a kind of guiding principle for what you're trying to achieve, and I think when you ask people, and we had about 11,000 responses to the consultation on the cancer plan, what people want above all is to know that their chances of surviving a cancer diagnosis are as good as they can possibly be. So reverting to targeting cancer survival as the overarching ambition obviously makes sense from that point of view. It responds to people's questions about the way the service operates and what they can expect from it. The difficulty is you can't kind of manage a system day to day on something which takes 5 years to read out, such as survival. And its 5-year survival is a pretty meaningful figure. Because the majority of people who are alive 5 years after a cancer diagnosis will have been cured of cancer, and then a smaller proportion will be living with cancer but having some form of ongoing treatment. So a 5-year survival figure feels like a good headline. What it then drives is all the underlying behaviors and ambitions to how you get to that point. And if you look at the maths of it, the majority of that is going to need to be about continuing our drive on diagnosing cancers as early as possible, because that's when you have the highest chance of curative treatment. And then secondarily, making sure that the accessibility of the most modern forms of treatment and the forms of treatment most likely to keep people alive is as good as we can make it. And both of those things are co-dominant priorities, if you like, for if you want to get to that level of survival.
Yeah. Can I just tell you, and I have again where I worry, because I worry, Peter. We had, didn't we? We had a headline. We had a retail offer at the top of the last cancer plan, which was I think the way we put it was that 2/3 of cancer will be diagnosed at stage 1 or stage 2. No, early diagnosis is cancer's magic key. You've put in the plan that will just increase the proportion of cancers diagnosed at stage 1 and stage 2. So while I appreciate that the headline is the 75% by 2035, how can we, the public, cancer community, judge you on whether you're just increasing the proportion of cancers diagnosed at stage 1, stage 2? Because we had made progress on doing that, but what would be success look like in that early diagnosis metric?
So as I say, you can't manage a system to something that takes 5 years to read out. So we've got a series of what you might call surrogate endpoints, shorter term readouts that we're going to be focusing on. One of them is what we've spent the last 5 years looking at, which is the rates of early diagnosis, the proportion of cancers diagnosed at stage 1 and 2. The flip side of that is that driving down the proportion of cancers diagnosed at very late stage, because we know that those have the worst prognosis. The third element is continuing to try and drive down the numbers of cancers that present as an emergency, either in an accident emergency or through urgent referral. There's somewhat of a limit to what you can achieve with that, and we could maybe talk about that, but driving down that proportion feels important. And the fourth key point is to continue to squeeze the gap between the best off and the least well off in terms of their likelihood of presenting with a cancer that's at a curable stage. So driving down the inequality gap in presentation. So all four of those intermediate readouts are wired into the way we're going to enact the plan and the things that we're going to monitor year on year to make sure that the things we're doing are driving that up. To your previous point about progress on early diagnosis, we spent a decade prior to the pandemic increasing the numbers of people referred in for investigation of cancer about 10% every year. So in about 2009, we had about 1 million people referred on what were then called the 2-week wait pathway. Last year, we saw 3.3 million people. So we'd more than tripled the number of people referred in just over a decade. And if you look at what was happening prior to the pandemic, we had seen no shift in the rate of early diagnosis. It was absolutely flat. We have seen an uplift since we came out of COVID. And if you look at the numbers, what you see in that is that's mainly driven by more people getting PSA tested because of a lot of high-profile people getting prostate cancer and talking about it, so people go to their GP and get their PSA measured. So we've diagnosed much more early-stage prostate cancer, and you can have an argument about whether that's a useful thing to do because many of them don't need treatment. But the other big contributor to that has been lung cancer, where we've enormously increased the rates of early diagnosis as a direct result of our lung screening program. And if there's a kind of macro takeaway from this, it's that simply waiting for people to come into the system doesn't appear to drive up rates of early diagnosis. Just bringing more and more referrals in doesn't appear to do it. But very targeted approaches, such as the lung screening program, where you invest specifically in a technology and you roll it out and you target it at the people most at risk of cancer, appears to be a much more effective way of moving the dial on that. So the latest figures suggest we're at about 60% early diagnosis from a baseline of about 54, 55%. So we have seen progress in the last few years.
And I know you're taking that win on the lung screening program, the supermarket screening as it's known, which was sort of pushed by my late colleague James Brokenshire, who's a member of Parliament who died of lung cancer, as we know. And I noticed that in the plan you're going to scale that up and roll that out further. So well done on that, James.
Yeah.
I have a couple of questions, Peter. That's so interesting what you said about the focused approach. Do we have the data to do that kind of risk assessment? And what are you doing to try and improve the kind of focus that the system can do in order to identify people who are at most risk? And I'm thinking here partly the genomic program, but also people's ongoing engagement with primary care.
Yeah. So what we would like to be able to do is to understand at a very fine-tuned level people's cancer risk. At the moment, what you can go on is mostly how old they are, whether or not they smoke, and where they live. And for using that, you can define a risk category quite well. The biological information about their genetic makeup is pretty uninformative, to be honest. And we hear a lot about sequencing people's genomes at birth, giving us a way of predicting what illnesses they're going to get. The read-through is extremely poor. And the dominant effect on cancer risk is one's environment and what people call the expososome, the things to which you're exposed and the way in which you live your life, some of which is modifiable and some of which is not. The potentially avoidable cancer risk is probably about a third of cases. It used to be 40%, but as fewer and fewer people have smoked, it's gone down to about a third. And a lot of that is really quite hard to tackle, but clearly we should be trying to tackle that. But that still leaves you with 70% of people whose cancer is down to bad luck and essentially failure of genomic repair. At base, cancer is about the repair mechanisms which allow us to regenerate our tissues and allow the body to differentiate into different things like eyes and hair and teeth and so forth. All those getting hijacked by the repair mechanism and that's what causes cancer to develop. And that's a feature, of course, of aging.
Well, the key word was just said there. So on that point, then, we're going to see 2.2 million new cancer cases in the UK by the end of this Parliament. So that will be a rise of about 21% on the previous Parliament. In other words, the amount of cancer being identified is growing quite a lot. And that is quite a lot to do with aging population, but it's also obesity, drinking, and the exposome, as you quite rightly said. Now, this cancer plan doesn't have much to say about upstream interventions. What it does say tends to point more to the 10-year plan. And the 10-year plan doesn't say that much either. And there isn't a macro strategy for trying to reduce the impacts on people from their behaviors and their environments. There's things that, is that a fair characterization? And are there things that you would like there to be that maybe aren't within the scope of this cancer plan, but we should all be thinking about?
Yeah, I think prevention is a whole topic in itself, and there's a moderate amount.
Podcast.
Yes, drawing my cue from the title. And clearly prevention is a big issue, and improving the general health of the population is a big issue. And when people make international comparisons about the way that the different health systems behave, they always point to Scandinavia as doing better. And there is no doubt that GDP per head in Scandinavia is better, levels of education are better, lifestyles are healthier, and so forth. So I think trying to re-engineer the way we live our lives is fundamentally what will make the biggest difference. Much of that is not specific to cancer, which is why the cancer plan hasn't gone into it in more detail. We've tried to focus on the things which are particular to cancer for prevention. So continuing to drive on smoking and the smoke-free generation legislation, continuing to drive on HPV vaccination and the eradication of cervical cancer, continuing to drive down on underage sunbed use and so forth. But you're absolutely right that if we could all take more exercise and be less overweight, then that would have a big impact on some of the cancer incidents. And there are some worrying signs that the rise of bowel cancer in younger people, although
what do you
it's starting
put that
at
down
a very
to?
low
Because
base.
it's a bit of a mystery to a lot of people. I can't understand it at all.
It is. There's a lot of research going into it,
Yeah.
and there is nothing clear and definitive at the moment. Most of us, I think, have a hunch that it's to do with our diet and the way we live our lives. And the fact that a high-fat, high meat-based Western-type diet produces a microbiome which is more carcinogenic than the more plant-based diet. Lots of work going into trying to understand the mechanisms of that. Work on diet is really complicated because it's very hard to get very accurate information about what people eat over a very long period of time, which is what you really need. But I think most of the people who work in this area are thinking in that way, and that clearly is about trying to affect people's dietary habits and to move people towards what we would regard as a more plant-based, less fat-rich diet.
I see that one of the other top lines is that you're going to meet the cancer waiting time standards by the end of the Parliament. So that's treatment within 62 days. Now that, as you know, hasn't been met since 2014. So, even before I was a minister, that hasn't been met. That, of course, can be tracked month on month as to how we're doing. And I just wonder, have you made a rod for your back there? Nothing wrong with ambition. Totally get you on ambition. But the government have said they're going to recover the 18-week target. And you've now said that you're going to recover the 62-week cancer target by the end of the Parliament. That is, Sarah Woolnough from the King's Fund, as you know, has been quite punchy in her response to the plan. Lots of people think that is very brave, Minister. Let's put it that way. What do you think?
I agree that this is not straightforward, but at the same time, I'm really pleased that it's in there, because what it does is it gives you the opportunity to focus the attention of the system on getting to that point. If you're running a large provider trust, a large acute hospital, you have enormous numbers of competing priorities for your attention and the attention of your management team, whether it's trolley waits in A&E, whether it's the routine waiting list, whether it's all sorts of other things. And making sure that cancer and the time it takes to get cancer diagnosed and treated is a priority for these organisations is absolutely critical for turning that around. We can see that there are hospitals in this country that are at or very close to the waiting time standards we want to see. We can also see that there are quite a lot that aren't. And a lot of the difference between those is about how well the administration, the management of the organisation and the clinical teams are aligned in their ambitions to deliver these things, and how energetic they are in pursuing the things that they need to do. Not all of this is about resource and capacity. There are, of course, capacity constraints. Diagnostic services, in particular, things like histopathology, radiology, can be real bottlenecks where you haven't got the necessary people or kit. But actually, a lot of this is about focus. The absolute numbers of people coming through cancer pathways, although nationally they're large, 3.3 million in a year, for an individual hospital are quite small compared to, for example, their elective waiting list. So a lot of it is about focusing on that problem and addressing it. And we see, and the hospitals we work with where they have real challenges with their waiting times, we can see that it's possible to make improvements, not just with short-term, waiting list initiatives and immediate measures that people tend to take to get their position better, but by thinking about how the pathways run, how to do things in the right order, making sure you've got the right diagnostics at the front end so that you can rapidly tell people they haven't got cancer, because the great majority of people referred on these pathways, of course, don't. So getting the order of things, getting the organisation right, can make a huge difference to this performance. And I think having that ambition to restore the waiting times by the end of the Parliament gives us the mandate to help people to transform the pathways and to put that focus into it. And I think that's absolutely critical.
Yeah, a couple other things in the time we've got left. Workforce. When we published the last cancer plan, I think I have said publicly, and I hopefully very honestly, that I think that the lack of a combined cancer workforce plan probably undermined my plan, and many of the stakeholders said so at the time. And I noticed obviously that the government's 10-year workforce plan, the refresh of the workforce plan a couple of years ago, is due out at some point in the spring, summer. I wonder, just looking at some of the stakeholder response, the Royal College of Radiologists said there was insufficient cancer staff to meet demand. Workforce surveys, they suggest there's a 30% shortfall in radiologists, a 15% in clinical oncologists. How closely has the development of the National Cancer Plan been working with the development of the 10-year workforce plan? Because if they're not joined up, then you're not going to get anywhere near 62.
Yeah, of course, we've had a lot of interaction with the people producing the workforce plan. We've seen quite a big expansion in the cancer workforce in the last 5 years. We have put in significant numbers of extra training places for diagnostic radiology, for clinical oncology, for medical oncology, for other medical specialties that are involved in the diagnosis of cancer. And we've seen a big uplift. My own specialty in medical oncology has grown by about 20% in the last 5 years as a direct result of those investments. And the projections are that we're going to need to continue with that, and particularly in some parts of the country, there are big disparities in the number of specialists. A few years ago, I looked at the number of oncologists we had, and there's a 5-fold difference between the centre of London and the East Midlands in the number of oncologists per head of the population. So we need to address those, and we need to make sure that we're getting people out to train in the places where we have fewer specialists, and that's a very specific ambition of the plan, and there's some forward-facing statements in the plan about specifically doing that and continuing to put the investment into workforce. So I think it needs to be done. Wherever you look, there are big pressures. Therapy radiographers, the ones who deliver the radiotherapy, are also very hard pressed, and it's a very rapid turnover workforce, and we need to continue to bring people into that profession. Nurses, and particularly specialist nurses, is another area where we really need to keep pushing. One of the good things about the plan is that we've got ring-fence money for the cancer alliances, which I think are really important structures for helping that. The Extend programme, for example, which does upskilling of specialist nurses to deliver cancer care, has been really successful, and we're going to continue to push that.
Peter, I'm really struck by a contradiction in what we're talking about here. You must have used the word specialist 20 times in the last 5 minutes, and you pointed quite reasonably to the difference between the specialist rates in consultants in London compared to the rest of the country. On the other hand, we have, as we know, a global problem with clinical workforce, that there aren't enough to go around. And this push to everyone being specialist contributes to the difficulties we're having in getting the right people on the ground. Shouldn't we? And we live in a world of AI where modern technology can support people to actually work at the top of their license. Shouldn't we be thinking in completely the opposite terms, and so that we have people who are enabled to do jobs that they couldn't have done 5 years ago, and we can expand capacity by broadening the scope of people's work rather than driving people down narrow channels? Now, I understand if I had cancer tomorrow, I'd want like the best person in the country looking at it. I'm not anti-specialism, but I'm just struck by this drive towards expertise and narrow fields, and also which runs in the face of the workforce problem we've got.
So lots in there.
I know. Sorry.
Number one, it's very noticeable that your access to the highest quality opinion and specialist care is variable according to where you live. Mm-hmm. And one of the big ambitions of the plan is to level that up and to make sure that people in relatively disadvantaged areas have that access. That doesn't necessarily have to be more and more and more people who are specialists. A lot of it's about connecting. Since the pandemic, we're all used to working remotely, and we can use our multidisciplinary teams to reach out to places where they previously might not have been consulted to get opinions there. And I think there's a lot more we can do in that area. Medicine is intrinsically complex and is always about sophisticated trade-offs between benefit and risk. And across that, you have the orthogonal question of what works, what is important for people, the people receiving the care. That is not something you can do by AI. That requires sophisticated human interaction to understand what it is somebody wants, what the risks are of a particular course of action, and what the benefits might be. You can make sure that they can get the information they need to have that discussion using AI, and I think there's a lot more we can do using technology, for example, to bring the data into the multidisciplinary discussions about what needs to happen. We're going to do some work to reform the way multidisciplinary team discussions go, to turn them from being a rather plodding bureaucratic process of going through every single case to choosing the cases which really need discussion and making sure that they focus on improving the quality of the results that they're producing. But in the end, you need a human brain that can integrate all those really complex inputs. And if AI can help us to do that, if AI can help us to examine CT scans faster, check mammograms faster, examine histology slides faster, that's great. But you still need the specialist human interaction. And we, all of us, know that the first thing that anybody thinks about when you've got a nasty diagnosis is, who is the best person I can go and consult about this? And whilst you can get to a certain point on Google, in the end you need to have a complex human interaction to make your decisions.
Yeah. Dr. Google. Peter, quick 60 seconds, end on a positive. Multi-cancer detection test seems to be one of the big bets that you've made in the plan. For those who don't know, this is a simple blood test that can really get into the early weeds of cancer detection. You know, things like pancreatic cancer, where often diagnosed way too late. The NHS has been doing the Grail trial with NHS Gallery trial, 140,000 people in that. I think you maybe expect in the spring that will come to its fruition. It seems very exciting. Is it as exciting as some are saying?
I've got a scientific background, so I keep an open mind till I see the data. We will see the data later on this year. I agree it's a really exciting potential development because it opens up a whole new set of possibilities for how you detect cancers early. There is a trade-off. If you're looking at circulating DNA, your tumour has to be large enough and growing rapidly enough to shed enough DNA into the bloodstream for it to be detectable. So very slow growing and very small cancers will be very hard to detect using this technology. Very fast growing cancers will grow too fast for you to be able to screen people effectively, because they'll grow in between the intervals at which you might screen them. But there's quite a big group of cancers in the middle which grow reasonably fast and which we find very difficult to diagnose: pancreatic cancer, esophageal cancer, some bowel cancers, ovarian cancer, where we might, I think, see a signal and we might see benefit from this approach. But we need to see the data.
Yeah, and just to crave your indulgence, story running today, testing period blood for signs of cervical cancer could be a new way of screening for the disease, which is obviously linked to what we've just been talking about. Obviously, the current test is the cervical smear test. Just your response to that story, it sounds promising.
I think it sounds really promising. Happily, cervical cancer is a diminishing problem as the HPV vaccination takes on the reduction in the incidence. But I think we are at a very interesting point in the development of all sorts of new biomarkers and different ways of detecting these changes in the cells of the body at an earlier stage. Lots of people looking at tests in urine, for example, to pick up early markers of transformation. Lots of different sorts of blood tests, and DNA is only the start of it. There's lots of different things you can potentially measure in blood that might be informative. So I think, as always, we need the technology, we need to evaluate the technology, and we need the human beings to do that.
Well done. It's a comprehensive plan, a lot of work. Obviously, the work now just begins. You've now got to meet all these targets, but we'll obviously put a link to the plan in the show notes. And may I just say, Peter, as always, you have a very reassuring and calming doctor's voice.
You do.
Well, that's
It's
very kind.
I'm gonna try and be more like you.
Yes, let's all try and be like Peter. Thanks very much.
Thank you very much, Peter.
Nice to
Really
see you.
appreciate it.
Take care.
There he goes, busy man. I like that voice though, James. Do you know what I'd like Peter to do? CBeebies bedtime stories.
He has a very lovely voice.
What do you think?
Listen, he is so reasonable, and the points he made, you can't fool him. I do worry about the lack of ambition, though, because we're living at a remarkable time when lots of things in our lives are going through an amazing revolution, and the technologies around health are incredibly impressive. And he is right to hold out for the data and to be skeptical on things like genomics. Absolutely so glad we have people like him to bring us back down to earth. But boy, oh boy, we've still got cancer coming up by 20% each parliament. And, no plan for attempting to reduce that number, and no improvement really at the diagnosis rate much. As he quite reasonably said, these are big problems. Like, what we should be nutting those out and trying to come up with a solution for bringing down, bringing down the rate of cancer and bringing up the rate of diagnosis. But
I hear you, but I mean, I think the multi-cancer detection test that I was just asking him there at the end, the Gallery trial with Grail. I mean, of course, is that prevention, is that detection, which then makes cancer more eminently treatable? It's probably more the latter, isn't it? Because it's not actually preventing it from happening in the first place.
Well, it's preventing severe disease, and so I think it's sort of okay.
But yeah, in terms of but the first question you were asking him is about, interventionism, basically, isn't it? Is, will the government be more interventionist in changing lifestyles in order to prevent cancers for the ones where you're not just unlucky, to use the professor's words?
I just point out, I don't disagree with the things he's saying, but the data we have on people is roughly where do they live, how old are they, and if we're lucky, how much they weigh. But for most of the country, we have no idea how much they weigh. So the idea of sort of polygenic risk scoring is we're meant to combine their biome and their bloods and their genomics and their lifestyle data to come up with this sort of 4D sophisticated analysis of their risk score. But actually, all we've really got is their postcode. I mean, it's like, okay, but couldn't we do a little bit better than that? And then in terms of diagnosis, I mean, things like the Grail test, sure, it's pretty complicated. There are shreds of this and that in all of our body, and some of it's meaningful, some of it's distracting. But can we not have a program for really leaning in heavily so that in 5 years' time, we're making more use of this? And then in terms of upstream primary prevention, can we not lean in on obesity and drinking and on cleaning up the air? We could really knock that cancer number on the head if we put our minds to it, really, without much change to the way we live. But there's just no ambition to do that at all.
100%. But we, as we say, that's the health bit. The politics bit, as I was saying earlier, isn't it? It's about authority. Is about authority. Where does the government have the authority? Does any government have the authority to, the dreaded nanny state, and to actually intervene and push down those numbers where it's not just bad luck?
I don't think it is. I think nanny state's dead. I was in Taiwan over Christmas. They have programs on. They've got rid of beetle eating. 20 years ago, when I used to go with my wife, it was just the whole place full. 2 of her uncles died of cancer of the mouth from beetle. Now, none of it. The air's all cleaned up. I mean, there is a national project to improve the health of the nation. We just don't have any of that ambition. So partly it's politics, partly it's just imagination and creativity and political skill.
Yeah, beetle eating. That's not a subject I thought we'd venture into.
Yeah, it's still nut, little red nut
on this
horrible
episode.
Yeah.
I just wanted to shout out that I noticed earlier in the week they said about funding travel costs for children, young people travelling for cancer costs. I wish I'd done that when I was a cancer minister. Credit to them. And, because there are a relatively small number of paediatric oncology units, specialist oncology units. And of course, there is quite a lot of travel involved for that. As long as that is fully funded, as long as it is easy to access, then, you're not made to jump through 1,000 forms in order to do it, then that's a really good thing. And well done to ministers for doing that. Very quick recommendation for you, James, considering that it just rains at the moment. If you fancy going to the cinema this weekend, I thought I would open the Prevention is the New Cure Film Club. So it was Mrs. Brine's birthday yesterday, as you know, and we went to the cinema last night in Winchester to watch the film. It's called Is This Thing On?, which is sort of it's an American film, but it's about a guy who takes to stand up when his marriage falls apart, and it's sort of based loosely on the life of the Liverpudlian comedian John Bishop, who I'm sure you're aware of.
Gosh, it sounds so obscure.
It's really obscure, but it's really sweet. And I don't go to the cinema very often, so for me to go and watch something at cinema is good. And they served you food in your seats.
Oh, lovely! I do like that.
Anyway, yeah, is this thing on? That is Steve's recommendation for the Bethell cinema weekend.
Yeah.
No.
Does it have guns? Does it have aliens? Doesn't seem to have like...
No, but all the trailers seem to have guns and aliens. In fact, it's supposed to be Valentine's Day next weekend. There's supposed to be a sort of soppy rom-com. I think that was about as soppy as it got last. Anyway, listen, you can find us on the social channels as always, and please give us your feedback on the interview with Peter and feedback on the show. We like to hear it, and you can email us preventionisthenewcurepodcast@gmail.com, and we respond to your messages. James, see you next week.
Thanks, Steve.